So is it visible, sir?
Yes, ma, it's visible.
Okay, sir. Good evening to one and all present here. Today's case presentation is about a preterm baby with breathlessness. So, baby of Vidya, a 33 days old female neonate who was firstborn of non-consanguineous marriage parents, born at 28 weeks plus 5 days of gestation, with a postmenstrual age of 33 weeks plus 3 days, was delivered by emergency LSES in view of decreased fetal movements on 27/7/2022 at 3:17 p.m. with a birth weight of 1.04 kg. And baby is admitted in NICU for respiratory distress and preterm care. Informant was mother and reliability is good. So antenatal history, G2, mother was G2A1. A1 was a spontaneous abortion 1 year back at 4 months of gestation. Married since 6 years and it was a non-consanguineous marriage. Pregnancy was confirmed by urine pregnancy test at 2nd month of gestation. And age at conception of mother was 26 years and it was a spontaneous conception. LMP was 28/12/2021 and EDD was 4/10/2022. And mother was a known case of overt diabetes mellitus on insulin for 2 years. And she was a registered case in our hospital. Blood group was B positive and total number of antenatal checkups was 8 and weight gain was around 5 kg. First trimester, there was no history of excessive vomiting, fever with rash, radiation exposure or drug intake, no history of any pets at home. Dating scan was done around 3rd month of gestation, but dates were not known by the mother. Folic acid supplements were started from 2nd month of gestation after confirming the pregnancy. In 2nd trimester, mother had spotting PV from 14 weeks of gestation on and off, for which she was admitted and was suggested bed rest. History of hospitalization at 20 weeks of gestation for elevated blood sugars, and her insulin dose was titrated and she was discharged after 5 days. She was diagnosed as hypothyroidism at 5th month of gestation and was started on medication for the same.
Okay,
no history of any.
Sir, can we interfere in between? Or
Yes.
okay. So in the introduction, you had commented about the PMA as well as gestational age. What are the first slide? So what are the things you are interested in?
Gestational age is when the baby was born, ma'am.
Yeah. That is okay. That you presented perfectly. Gestational age and postmenstrual age. Then what else you can add here?
Postnatal age is 33 days, ma'am.
Okay, so that also can be added. Though you can calculate from the postmenstrual age, it is better to add the postnatal age so that you have an idea about the baby. Okay,
ma'am.
And it's always better to just blind the name of the patient.
Okay, ma'am.
Without explicitly telling the name of the patient. Okay, fine.
Okay, ma'am.
Next slide. Fine. Okay, you can proceed.
Okay, ma'am.
So what do you want to comment about the weight gain of 5 kg?
Since it is a preterm delivery, we cannot comment at present, ma'am.
Okay, since it was a 28 weeker, you feel 5 kg would be appropriate. Fine. Okay, next.
There was no history of any pregnancy-induced hypertension, urinary tract infection, or leaking PV. Anomaly scan was done at our 5th month of gestation was normal. Quickening was felt at 6 months of gestation. Iron, folic acid, and calcium supplements were taken. And injection TD 2 doses was taken at 5 months and 6 months. At 28 weeks of gestation, mother had reduced fetal movements, for which scan was done.
Scans you are interested in? First trimester, what is the scan you are interested in? You told about the scan in the 2nd trimester, right? So
yes,
first trimester, what is the scan you are interested in? 2nd trimester, why are you interested in scan? What do you want to look in the scan?
First trimester dating scan, ma'am. For appropriate gestational age, we can tell by dating scan.
Fine. Okay.
And for anomaly scan, mainly to look for any anomalies.
So when do you do this 2nd trimester anomaly scan?
Around 16 to 20 weeks, ma'am.
Fine. Okay. 3rd trimester, yes, carry on.
3rd trimester at 28 weeks of gestation, mother had reduced fetal movements, for which a scan was done, was found to be normal. And subsequently, she developed abdominal pain and was advised IM injection 4 doses for lung maturation. And she continued to perceive persistent reduced fetal movements, for which she was taken for emergency LSES.
So what are the things they will do when the mother is coming with reduced fetal movements? Okay. So what IM injection they would have given?
Antenatal steroids, ma'am, for lung maturation.
Okay. So 4 doses they have given. What do you think? What they would have given? What steroid?
Dexamethasone.
Fine. So do you know the dose of dexamethasone?
Dexamethasone 6 mg will give Q 12th hourly for 4 doses, ma'am.
Fine. So when the mother is coming with reduced fetal movements, what else they will do? OBG, obstetricians, what else they will do? The mother is coming, getting admitted, 4 doses you are giving, then what else you will do?
Like for preterm delivery, we can give magnesium sulfate also for neuroprotection.
Very good. Then
tocolytics can be given to arrest the preterm labor.
Very good. Then what are the history? Mother has come with pain, right? So what
Yes,
other
ma'am.
histories you should ask? Do you have any other history in the next slide?
No, ma'am. She had only abdomen pain and decreased fetal movements, ma'am.
So what other history you are interested in?
Any history of any bleeding PV?
Okay, bleeding PV. Very good. Then
any fever, foul smelling discharge?
very good. Fever, foul smelling discharge. Then the membrane is intact or ruptured? Any
ruptured. Yes, ma'am.
Will ask, right? Why it is important?
For Korean, like PROM, even for 1 hour is significant in preterm babies. PPROM.
Okay, PPROM is significant. This is a preterm
Yes, ma'am.
baby. There can be PPROM. Okay, so why are we so concerned about PPROM?
It is a risk factor for sepsis in the baby, ma'am.
Very good. Okay. So, and also you will ask what other infection you will ask. You had already mentioned in your slide. What other infection you will ask just before delivery? So any signs of infection, chorioamnionitis you told, rupture of membrane, fever, foul smelling discharge, all those things you told. What other thing you will ask? What other infection can be there before delivery?
I mean, UTI history will ask.
Okay, fine. So UTI history also you would ask. Okay, then what other monitoring you will do? So 4 doses. So mother is admitted for 2 days approximately.
Yes, ma'am.
So 2 days, what you would be doing? You told magnesium sulfate you can give. Then what other thing you will do? You would monitor only fetal heart rate using stethoscope, or what you will do?
No, NST we can do, ma'am.
Okay, NST, they would have done a NST also, and they would have done scan also to see how much is the Liker, everything they would have done. So NST is more reliable after 32 weeks. Okay, this can be, it is also used for monitoring even preterm babies.
Okay, ma'am.
So 28 plus 5 means what do you use the term? Okay, we'll come to it later. Next slide.
A female baby was delivered by emergency LSCS in view of reduced fetal movements at 28 weeks plus 5 days of gestation on 27/7/2022 at 3:17 p.m. with a birth weight of 1.04 kg. And at birth, parents were told that baby had weak cry and poor respiratory efforts, for which O2 support was given, and baby was shifted to NICU in view of severe respiratory distress and for preterm care.
What other intrapartum history you are interested in, doctor? Suppose if you
are... Otherwise, how do you prepare yourself for receiving a preterm delivery? How do you prepare yourself for receiving preterm delivery? And as madam told, what are the things you want to prepare yourself? Okay, further inputs you want?
There should be a warmer in the delivery room, sir, and plastic wraps to prevent hypothermia, and transport incubator, and CPAP O2 support we should check, TP's resuscitator, and other for routine resuscitation measures, whatever we check, everything should be ready. And prior to that, we should do preterm counseling also to the parents.
So what are you going to counsel?
About the
no, baby is not expert, right? You are giving counseling and you are going for resuscitation. So what would you counsel and go for resuscitation?
We'll counsel about the various complications after in preterm baby, ma'am. All the complications we'll counsel the parents, and the need for surfactant therapy, and the need for prolonged NICU stay.
Very good. Okay, so duration of ICU stay and short term, what are complications, long term complications you would be explaining. Okay, then what else you would do? Baby is delivered. Okay, you arrange your equipment, warmer, incubator, everything. So what else you will be more concerned? Preterm baby is coming out of the birth canal. So what else you are interested? What else you would like to do?
First, we should receive the baby under radiant warmer and wrap the baby with
immediately after delivery. Do you want to take
delayed cord clamping, ma'am?
Fine. So for delayed cord clamping, what has to be present? For all babies, do you go delayed cord clamping? 28 weeks. So what you will see and decide?
The baby has cried after birth. Respiratory efforts we'll see.
Very good. So you will see whether baby is having respiratory efforts. If there are respiratory efforts, you would go for delayed cord clamping. Why do you think delayed cord clamping is very much important?
It has been associated with the decreased incidence of anemia in later life.
Okay. So something else, you know, some other complications can it prevent?
Any other complication, long-term complications?
BPD, ma'am.
Okay, so it can prevent intraventricular hemorrhage.
Very good.
Okay, it decreases IVH incidence also. Since it is a 28-weeker, we are concerned about IVH, intraventricular hemorrhage. So it can decrease IVH also. Okay. So TP is resistant.
Can I ask a question?
Yes, sir. Yes, sir.
Yeah, Vishnupriya, you're doing excellently well. Now, you said you wanted to delay cord clamping. Now,
Yes,
has it so you said it will increase the transfusion, and then probably the anemia incidence will come down, and then now the moderators told you about the long-term outcome. There are some implications as well. Now, your topic is on respiratory distress. So, any intervention that you do, you should know everything. So any impact it will have on the immediate presence of respiratory distress or not, if you delay cord clamping and if you do not delay cord clamping. Just think. I wanted to always when as a postgraduate, you should be thinking out of the box. You should learn to think out of the box.
Yes.
Whatever you do, never work as a, like somebody told me, so I am doing. You should always think, why am I doing it? So why do you want to delay cord clamping? To prevent respiratory distress. If I say that it will reduce the respiratory distress, anything else, just look at the physiology. All right, I'll give you some clue. Of course, delaying cord clamping is one intervention where you actually do something to do with the output of the left ventricle. Can you now try to answer? When do you actually, when the resuscitation protocols as of now recommend delaying cord clamping only if baby is vigorous at birth, isn't it?
Yes, sir.
Yes, sir.
So in a baby, say ideally the three questions, this is just basic NRP which you are already aware of. I'm just trying to, I'll come back to you to answer the question. I'm just giving you some time to think. So you ask the three questions: is the baby term? Is the baby having good respiratory effort? And is the tone good? If the answer to all the three questions is yes, you will delay cord clamping. But this is not an answer to first question. In our case is no. Still, you would like to, now we say we would like to delay cord clamping. Why? Because is there any condition? Question before you answer that, is there any condition that baby has to be fulfilling before you decide to delay cord clamping? Baby has to be vigorous at birth, isn't it? Depressed babies, you may not, you will immediately. Now come back to the question. Can you answer? All right. So let's not waste time. So the key, yes, you are answering. Yes, please go ahead. Please go ahead. All right. Let us not waste time. So the key organ I said is left ventricle. Left ventricle has to function. Left ventricle output has to improve. So the output always, cardiac output always comes from good preload, isn't it? And the good preload is because there is a supply of steady supply of blood from the placenta. And what happens at birth? You clamp the cord. When you clamp the cord, unless the baby is vigorous, what doesn't happen? Because what is the supply of preload at birth? Suddenly it changes to the lung. So if the lung is not aerated, this is not going to happen. So if you are giving some time for a vigorous baby for the lung to aerate well, so that the transition is smooth. Are you getting my point?
Yes, sir.
So that is probably the directly important. So you delay cord clamping, the immediate respiratory distress also will come down, probably. All right. And because of this, now how do you delay cord clamping? Since you are at this, we'll just finish this and then we'll let you go to the next step. How do you delay cord clamping in a preterm baby? What is the difference between delaying cord clamping in a preterm baby versus a term baby who is vigorous at birth? Is there any difference? You did not mention some of the preparatory things, the things you need to prepare for a preterm birth, or at least I did not hear. My net, I'm in Tirupati, my net connection is poor, so probably I don't know. I did not hear you saying.
We'll delay by 1 minute, sir.
Yeah. Okay. Why do you want to delay by 1 minute? That's a different question. See, this is how you get stuck in exam. You answer something and then you have to get out of delay cord clamping. How do you get out? By answering well. 1 minute, probably because 70% of the transfusion takes place by then, and then because of various other reasons. They come back to the question. So what is the difference between a term and a preterm delaying cord clamping? That is the question. We have modified the question now.
In preterm delaying cord
Any additional?
Sir?
Yes, go ahead.
It also reduces the incidence of BPD, later BPD also it helps to reduce.
No. Forget your BPD. We are talking, we are still in the golden hour.
Okay, sir.
What is the preparation of, what is the difference in the preparation of a preterm birth as compared to a term birth? What is the difference in the preparation that you should have mentioned? I did not hear you mention.
In preterm birth, we should have additional plastic wraps to avoid hypothermia.
So now take the, okay, now take the clue and then answer this question. One question, if a different question comes in exam from the previous question, it is only because the examiner is helping you to get the clue. If you answer the previous question, you will come back to this.
Okay.
So plastic wrap. So what is it that you want to do additionally in a, what does the NRP say? Additional precautions required when you delay cord clamping in preterm? Multiple thermal intervention. So which means that baby, you have to prevent hypothermia during this, because you are at a risk of hypothermia during this if you do not immediately keep the baby under
warmer.
And if you do not, the hypothermia is a much bad outcome to have than getting some advantage out of delayed cord clamping. So hypothermia has to be prevented anyway. So multiple interventions to prevent hypothermia, and one of the major interventions you did not mention. So what do you do as soon as this 1 minute? Where is the baby going to be? Of course, you will wrap it in you said plastic wrap. So immediately you will put in the baby in a plastic wrap. And where is the baby going to be in this 1 minute when you delay cord clamping?
On the mother's abdomen.
On the mother's chest, abdomen. Perfect. So that means you are initiating another concept called zero separation there. Okay, this is a new concept. Pre-render of your kangaroo mother care. So you have to at birth, if preterm baby is vigorous, you wrap the baby in a polythene or do some multiple intervention, not just one intervention alone. And instead of warmer, you would use a mother's
abdomen, chest and
mother's chest. And if you can ensure that, then only delay cord clamping. If you cannot ensure that, it's better that You forgo, you clamp immediately because temperature you cannot forget. Is that clear?
Yes, sir. Yes, sir.
Okay, good. Please proceed.
Okay, sir.
Usha, all yours, sir. I just interrupted. That's all.
No issues, sir. Sir, kindly interfere, kindly ask questions, sir. Okay, Dr. Vishnupriya, can you switch on the video? Some of the panelists wanted you to switch on the
Yes,
video
sir.
as well.
Yes, sir. Yes, ma'am.
What happened?
1 minute, ma'am. Not.
If it is not possible or taking time, you leave it.
Yes, ma'am. It's. 1 minute, ma'am.
Fine, Dr. Vishnupriya. You carry on with your slide is not seen. You project your, you share your slide.
Yes, ma'am. Is it seen now, ma'am?
No.
No, yeah. Now it is seen. Okay, so you told that you are receiving the baby, you are keeping over the mother's abdomen, you are allowing delayed cord clamping for 1 minute. Okay, what else you want to do? So in that 1 minute, as sir asked,
Yes, ma'am.
okay, for temperature regulation, what other thing you would have taken care of before delivery of the baby? One thing you told you will arrange for plastic wrap. Other things?
Radiant warmer, ma'am.
Okay, so radiant warmer what? Radiant warmer will be present in all the OTs,
Yes,
right?
ma'am.
What you wanted to do specifically?
Ma'am, I can't get you, ma'am.
What you wanted to do specifically with the radiant warmer? It will be anyways available in OT.
Yes, ma'am.
Temperature monitoring.
Okay, so you are going for resuscitation. What do
Yes,
you,
ma'am.
the warmer should be ready, or you are going to go and switch on. What are you going to do?
It's 8 o'clock.
We should pre-warm before the delivery, and all the sheets and towels should be pre-warmed, and cling wraps should be ready, ma'am. And
So how
also,
much time? So how much time will it take? How much time prior you would have switched on the warmer before delivery of the baby?
20
I mean,
20
what
to
mode
30
you
minutes.
have to use, what mode you have to use, and how much time?
Manual mode.
100% output will keep.
Okay. How much time before the delivery of the baby?
15 to 20 minutes before the delivery of the baby, ma'am.
Okay, so it is 20 to 30 minutes. Then what else you will take care of for thermoregulation? Warmer, plastic wrap, then?
Head cap.
Fine, very good. Head cap, then?
And transport incubator also should be there, ma'am. While transporting also, baby should be transport.
What else? What else? AC will be there in OT or not?
Yes, ma'am. Room temperature also we should maintain.
What you will maintain? How you will maintain? What is your target temperature, room temperature?
26, ma'am.
26 to 28 degrees Celsius. So
Yes,
what
ma'am.
would you do? You will ensure that the room temperature is 26 to 28 before
delivery. Yes, ma'am.
Okay, so plastic wrap you told, room temperature, warmer should be pre-warmed, linens should be pre-warmed, transport incubator should be ready, cap should be present. Okay,
Yes,
all these things you have arranged before delivery of the baby. And
Yes,
you are
ma'am.
now allowing the baby to get extra blood by delayed cord clamping.
Cord clamping.
So during that time, what are you going to do? You told you will put on the mother's abdomen. What else you will do?
We look for the respiratory efforts.
that
Whether
you
the
will
baby
not-
has cried.
Okay, so what
Any
else?
if any secretions are there, we'll suction
Fine, okay, then?
and dry the baby.
Okay.
And if the baby has
So will
not,
you dry this baby?
ma'am?
Okay, dry the baby,
then after cord clamping, we'll bring the baby to the radiant warmer, ma'am.
Okay, so when are you going to use your plastic wrap?
Immediately after delivery, ma'am.
Then how will you dry the baby? Okay,
Yes,
less than
ma'am.
32 weeker, you will receive the baby in the plastic wrap. Only
Yes,
extra
ma'am.
blood, whatever is blood clots, all those things you will wipe off, but you won't dry the baby. You will receive the
ma'am.
baby in the plastic wrap. Okay,
Yes, ma'am.
and it will be outside for resuscitation.
Yes, ma'am.
You are now you are clamping the cord, bringing the baby to the warmer. Okay, then tell me what are you going to do to this baby? You are telling poor respiratory efforts. So you
Yes,
have
ma'am.
brought the baby to the warmer. What are you going to do for this baby? So for the
Like,
respiratory support of the baby, what are the extra equipments you will arrange for this 28?
Preterm delivery.
CPAP, ma'am.
CPAP. So CPAP.
Delivery room CPAP.
So
No,
you see,
madam is asking any other facilities is required. Okay, do we need to use ambu bag alone is enough or any other facilities you require for a
No,
preterm
ma'am.
delivery?
TP resuscitator.
okay, TP is resuscitator. Then what
Okay.
else?
Any other?
After giving ambu, also baby did not cry. Poor respiratory efforts are there. No? We can intubate the baby, ma'am. For we should need a laryngoscope and ET tube.
Any oxygen devices additional you
So
want?
you want to give ambu to the baby. Then why do we have TP's resuscitator? You want to give ambu or you want to use TP's resuscitator for this baby?
Initially, we can if the respiratory efforts are poor, we can give ambu and we can try and see, ma'am. If there are there are persistent poor respiratory efforts, then we can put on a CPAP and we can intubate, ma'am.
Then what is the use of TP's resuscitator?
TP CPAP will start the baby on, ma'am.
Hmm?
TP CPAP will start the baby on, ma'am.
TP's CPAP. She is telling that she wants to give PPV, so she wants to use ambu, right?
Yes.
So for giving PPV, two things are, ambu is there. So what do you want to use for giving PPV? You are having ambu bag, you are having TP's resuscitator. So now you wanted to, she is feeling that baby is having poor efforts and you wanted to start the baby on PPV. So which equipment will you use? Yeah, something you tell. You're wasting time, right?
TPs also we can use, ma'am.
TPs also we can use. We can use many things, but what do you want to use?
This preterm delivery, madam is asking any other additional equipments you require in.
Oh,
I have
to
two
support,
options.
sir.
I am giving you two options. TP's resuscitator, ambu. Which one you will use to give PPV to this baby? Why?
TPs will be used for preterm babies, ma'am, so that we can control the PEEP delivered to the baby. So we'll use a TPs over plain ambu, ma'am.
So how do you control PEEP delivered to the what can you expand the PEEP, whatever you are telling?
Peak expiratory pressure, ma'am.
Peak expiratory pressure. Okay. Dr. Vishnu Priya?
Yes, ma'am.
What will you control using TP's resuscitator, which you cannot do in the ambu bag?
PEEP, ma'am. Peak end expiratory pressure.
Positive end expiratory pressure.
Okay. Positive end expiratory pressure, can you give in ambu or you cannot give?
Ambu we cannot give, ma'am.
In TPs we can.
TPs we can set.
So why is it important? You are telling ambu. If I give PPV, okay. Other persons also, Dr. Reshma, Dr. Shobana also can try answering for the questions. It does not mean that only Dr. Vishnu Priya should answer. Okay. So you are saying PEEP cannot be positive end expiratory pressure can be provided only by the TP's resuscitator. Okay. Sometimes in ambu bag, PEEP gauge will be connected. So that case PEEP can be provided using ambu also. But normal ambu, whichever we are using, will not give PEEP, positive end expiratory pressure. So why you think that the TP's resuscitator can give PEEP and you will use only TP's? Why PEEP is important?
Prevents BPD, ma'am. It's for prevention of BPD, bronchopulmonary dysplasia. and any lung injury.
What is the other advantage of TP's resuscitator? You are telling PEEP, I can provide only using TPs. What is the other advantage?
We can prevent air leaks and pneumothorax, ma'am.
Wow. That's what I'm asking. How?
We in TP's resuscitator, we can set a PEEP, ma'am, like at which it should be delivered.
What is
In
this
ambu,
PEEP you are talking about? Can you spell it out? P?
Positive end expiratory pressure, ma'am. PEEP.
That already you are told, right?
Yes, ma'am.
PWP already you told. It is not given in AMBU. It can be given using TP's resuscitator.
Yes, ma'am.
What else? I'm asking the second advantage.
Peak inspiratory pressure.
PIP, ma'am.
Also can.
Peak inspiratory pressure? Complete
PIP also can be more, regulated in the case of TP's resuscitators. When we use TPs, we can also regulate the PIP, ma'am, along with PEEP.
Okay, so PIP cannot be provided in AMBU? Can't the PIP be provided using AMBU? Okay, so the advantage is this one you need to know. Okay, AMBU bag cannot be used. Ideally, okay, whichever. Ideally, legally, TP's resuscitator should be present in the delivery room when you're going for a preterm resuscitation. Even for a term baby, giving PPV by TP's resuscitator is preferable because of two advantages. One is PIP. When you press a AMBU bag, okay, Dr. Vishnupriya might give a PIP of 25. Okay, Dr. Reshma might give a PIP of 15. Okay, another person can give a PIP of 30. So it is not regulated. How much PIP is delivered is not regulated. There is no control. Okay, only if it goes above 40 centimeter water, the pop-off valve will open up. Otherwise, you can give any amount of pressures. It can cause air leak. Second advantage, so this can be controlled by setting a PIP in the TP's resuscitator. Next thing is PWP. Why PWP is important for a preterm baby? Do you want to answer this?
It will help. It will help in opening up of the alveoli, ma'am.
Okay, so why a term baby also will need something to open up? No, why it is more important in a preterm baby?
The surfactant levels are very much reduced in preterm babies, ma'am. So the baby require extra support for maintaining the end expiratory pressure, so that we are artificially providing through outside sources, ma'am.
Okay, so baby is not able to maintain FRC, functional residual capacity, for which surfactant is needed. This baby, you are thinking surfactant deficiency. So to recruit or to open up the alveoli, PWP needs to be provided. What other equipment you need? That's what I'm again and again asking. Okay, TP's resuscitator is ideal. You are brought to the delivery room. What other equipment is mandatory?
Mandatory. What is equipment is mandatory to be kept for delivery of whenever you attend a delivery, you need something. You can't resuscitate in room air. What else you get?
O2 support, sir.
Yeah, oxygen is present in the OT. What else you need?
Need something for a preterm.
Oxygen will be present, right, in the OT?
You have oxygen, you have room air. Okay, so what else you get? What?
Blender, sir.
Okay.
Blender.
So blender is a must. TP's resuscitator and blender should go together. Okay. What is the advantage? Why do you need blender? Why can't you? You told O2 support is there in the OT. Why do you want to have blender? You can directly attach flow meter and take and connect to the TP's resuscitator. What is the problem?
We should for preterm babies we should start resuscitation with FaO2 of 21 to 30%, ma'am.
Okay.
So we need a blender.
To maintain the target saturation also, it will be helpful, ma'am. The blender will be helpful to maintain the target saturation.
Okay, so won't the oxygen from oxygen flow meter, if you attach a tube, won't it help? It will also help to maintain saturation, right?
What injury is prevented or what?
So how much FiO2?
Oxidative injury.
So if you are
We should
connecting
avoid hyperoxia.
hyperoxia, okay. So if you are connecting oxygen to ambu bag, okay,
Yes, ma'am.
without reservoir, how much FiO2 it will give to the baby? Around approximately. Around 40, right? With reservoir, it will give around 90. But if you want to give 30%, 25%, 35%, like that, blender is useful for titration of FiO2. You cannot titrate saturation. You can titrate only FiO2.
Yes,
Okay. So this baby is delivered. What are the parameters now you are going to set in the T-piece resuscitator before delivery of the baby? You cannot set PEEP after delivery of the baby.
Yes,
So
ma'am.
would you set PEEP and PEEP in a T-piece resuscitator? Just grossly you tell, how do you set PEEP and PEEP? You would have done no during resuscitation.
PEEP of around 4 to 5 centimeter we can set, ma'am.
Okay, you PEEP both we are hearing as like same. So you just tell PWP.
PWP எவ்வளவு வைப்பீங்க?
PWP around 4 to 5 centimeter, ma'am.
Okay, PIP. So PIP you will set around 10 to 15 centimeter water. And flow, how much you will keep? Flow. If you are connecting from one flow meter, you will keep 10 liters flow. Okay, even in the blender flow meter will be there now. You will set at 10 liters. This is a standard for any resuscitation in NRP. Okay. So now you have put a plastic wrap. You are thinking baby is having poor respiratory efforts and you have started PPV with T-piece resuscitator. So someone told about now it is 2 minutes of life. What is your target saturation?
65 to 70, ma'am.
65 to 70. Okay. So now you have started with 30% FiO2. Saturation is 75.
Ma'am, I didn't get you, ma'am.
You have started with 30% FiO2 in the blender.
Yes, ma'am.
Saturation is 80. What do you want to do? At 2 minutes.
Saturation is 80, ma.
At 2 minutes of life, saturation is 80. You are giving a FiO2 of 30%. What do you want?
We can reduce FiO2, ma'am.
Okay, you need to reduce FiO2.
Yes, ma'am.
Okay, to maintain the target saturation. Why you are so particular that we have to use blender? We have to target the saturation. We have to decrease FiO2. Why you are so particular in a preterm baby?
We should not hyperoxia. We should not give, ma'am. We should avoid hyperoxia in preterm babies.
Okay, why? Why hyperoxia has to be avoided? What all it can lead to?
What all problems baby can have if there is hyperoxia?
Retinopathy of prematurity.
ROP.
Okay, ROP. Then
barotrauma also can occur.
Barotrauma, it will occur with oxygen. Okay, ROP. Then
any complications if you maintain the targeted saturation? Okay, any complications can be avoided later.
BPD, ma'am.
okay, so it is chronic lung disease and retinopathy of prematurity. Oxygen-free radical-induced injuries. Okay, come to next slide. So how are you going to shift this baby now?
In a transport incubator connected to a CPAP, ma'am.
Connected to a CPAP. Okay, so then head also, do you want to cover using the cap?
Yes, ma'am.
Why?
Head has a maximum surface area. We should cover it to prevent hypothermia, ma'am.
Fine. So now you add this plastic wrap, transport incubator, all those things. Any other thermoregulation mechanism are you aware of?
Warm mat.
Something you are telling.
Warm mattresses.
Okay, there are some mattresses, phase changing material, mattresses with phase changing material, which can also be like what Manoj sir told. One mechanism might not be enough to maintain thermoregulation in a preterm baby. So you need to use multiple interventions.
Yes, ma'am.
Okay, so mattresses, plastic wrap, incubator, all those things can be used to maintain temperature. So you can go after the session, you can see also phase changing material. There are some trade names like Embrace, all those things.
Okay, ma'am.
So those mattresses, you can see how it is opening, how they are keeping the baby inside. You can see those videos. And I wanted to ask you, like, did you mention about gravida status of the mother? I didn't hear properly.
Yes, ma'am. G2A1, ma'am.
G2A1. So what? Suppose so why gravida status is important?
Previous history of any preterm births.
Okay, so why it is relevant?
If the first baby is a preterm baby, the next pregnancy, the chances of preterm is fourfold more, ma'am.
So not fourfold more. It is just 15 to 20% higher risk than a normal baby. Okay, if the previous baby is a preterm, then what other thing will you ask? If there is a previous live baby, what other thing you will ask?
Any NICU state, gestation of the baby, any NICU state, whether baby cried at birth.
All those things, course you will ask, preterm baby, whether how is the baby doing, developmentally normal.
Yes,
what other thing you will ask? What other thing you are interested in?
Spacing, ma'am, birth spacing.
Very good. So interpregnancy interval you will be asking. So what do you think? What is the ideal spacing should be?
2 years, ma'am.
2 years. Fine. Go ahead with the case presentation. Yeah.
On day of life 1, mother was informed that baby received some medications for lung expansion within 2 hours of life. Baby was connected to mechanical ventilator and was started on IV fluids and medications to aid the child's breathing. Umbilical line was secured for IV medications. Mother gave colostrum on day 1 of life, which was given via oral swabbing. And sugar monitoring was done in view of...
Suppose mother is telling baby was on ventilator. Okay, she will not know all these things, no? Invasive ventilation, non-invasive ventilation, all those things she will not know. Suppose you are asking history after some time. So what you will ask? How will you ask what mode of ventilation? Even when you are saying mechanical ventilator, even we also don't understand, no, whether it is invasive ventilation, non-invasive ventilation. We are not aware. So how to elicit that history, and is that history important?
Yes, ma'am. We can ask whether any tube was put in the airway, any tube was secured in the airway, or whether baby was on only nasal prongs.
Okay, so what was this baby having?
This baby, there was a tube secured in the airway and was connected to a machine, ma'am.
What do you think? Invasive ventilation, like putting a tube inside and mechanically ventilating the baby, or putting a CPAP, which one do you feel it is better?
Putting a CPAP is better, ma'am. Invasive ventilation, we should avoid.
Did baby received invasive ventilation?
Because baby had poor respiratory efforts at birth, ma'am. In spite of giving adequate resuscitation measures, baby had gasping and poor respiratory efforts. So we intubated and we shifted to NICU and connected on a ventilator, ma'am.
Okay. So if the baby is having a not so good intrapartum course, what else you will ask the obstetrician to take or to tell you during delivery, after delivery? What are the things you are interested to know? I mean, you are bringing this baby. What else I will ask you?
Whether any magnesium sulfate was given to the mother.
Okay, so why you are so particular? You are telling again and again about magnesium sulfate, no? Magnesium sulfate, what is the role? Why we need to give 28 weeker magnesium sulfate? Why do you mention again and again magnesium sulfate?
Can cause respiratory distress in the baby, ma'am.
So why do you, first you told, no, the 2 days 4 injections they gave antenatal steroids, but they didn't give magnesium sulfate. So why do you want them to give magnesium sulfate?
Neuroprotective.
Neuroprotective, ma'am.
Neuroprotective. Then you are now saying that no, it is bad. It will cause respiratory distress.
it helps in decreasing the incidence of BPD, NEC, IVH.
Okay, you are confused. You are confused between steroids and magnesium sulfate. Magnesium sulfate, as you told initially, it has only the neuroprotective effect. Okay, it does some mechanism, decreases some excitotoxicity, all those things, and in the long run, it will decrease the motor disabilities in the baby, cerebral palsy, all those things. So it is predominantly used for neuroprotection. It does not have any role in decreasing IVH or NEC, all those things. Okay, so how does antenatal steroids help? How does antenatal steroids help?
It helps in enhancing the surfactant production.
Okay, then? What is the thing? For magnesium sulfate, you are telling many things, no?
It also reduces respiratory distress syndrome.
Okay, both are same, right? RDS and increasing surfactant synthesis, both are same.
Yes, ma'am.
Preventing IVH.
Also, intraventricular hemorrhage and necrotizing enterocolitis.
Okay, so as of now, it protects against IVH. It decreases the mortality. As such, it decreases the mortality. That should come first. Mortality decreases, RDS it decreases, IVH it decreases developmental delay in the childhood. Okay, so leave. Again, we are going to the antenatal part. Okay, so let us come here. You have received the baby in the NICU. So you are giving invasive ventilation to this baby. So why you say that yes, ma'am, CPAP would have been better if the baby was breathing. So why do you think CPAP would have been better?
On ventilator, it is an invasive ventilation, ma'am. It might be, it can cause ventilator-induced lung injury by itself.
Okay. So another thing is how long this baby was connected to the ventilator. Are you going to say that?
Yes, ma'am. Yes, ma'am. I'll tell in the next slide, ma'am.
Okay. So baby is intubated. Okay. What are the things intubated and connected to and is receiving invasive ventilation? Okay.
Yes, ma'am.
You are afraid that baby will have ventilator-induced lung injury. So how will you prevent that when the baby is on invasive ventilation?
We should, if the saturation, we should try to wean off the baby from ventilator as soon as possible.
Very good.
Okay. Based on the
as soon as
saturation.
possible, you wanted to wean off the baby. Then what else?
We should give adequate PEEP FiO2 and.
So how do you decide how much PAP to give, how much PEEP to give, how much FiO2 to give when the baby is intubated and on ventilator? How do you decide?
Based on the Silverman-Anderson scoring, ma'am.
Okay.
Based on the severity of the distress.
What are the components of Silverman-Anderson scoring?
Upper chest retraction, lower chest retraction, xiphoid retraction, expiratory grunt, and NAS dilatation.
So will you be able to hear grunting once the baby is intubated, connected to ventilator?
No, ma'am.
So how do you decide your parameters? PAP, PWP, I'm not asking about mode and all. How will you decide about PAP, PWP, FiO2?
Based on the saturation level, ma'am.
All the three parameters you will decide on based on the saturation level?
Now, what you will monitor, what you will look?
Monitor what you will look, and in the baby what you will look. So how will you adjust these three parameters?
The monitor, we look for the saturation. Like in preterm, we should maintain saturation between 88 to 93. And the baby, we should look for any worsening of
88 to
distress.
93, that we used to tell before. Okay, now term or preterm, whatever it is, it has to be maintained above 90, 90 to 95.
Okay, ma'am.
Okay, is a target. Okay,
Okay.
very good. So you
Usha, just one, I know, just because this is a very basic concept she's
Yes, sir.
making, she can be this thing. You talked about oxygen the saturation level of 88 to 92, isn't it? So, like,
Yes, sir.
why do you, I mean, like, so why not have 100%? 100 saturation?
We should avoid hyperoxia and preterm, sir, to prevent the future development
Suppose
of
the
PPD.
baby is not on any support, not on any respiratory support, and then saturation is 100. Is that wrong?
No, sir.
Is there a problem that baby will have oxygen toxicity?
No, sir.
Yeah. So your concept should be very clear. A baby who is on supplemental oxygen, whether through a invasive ventilation or non-invasive respiratory support, or what a modality of supplemental oxygenation, if you are going to give oxygen, the target is 90 to
90 to
95.
95%. Yes, sir.
95. If you are not giving oxygen, then it can be 90 to 100. But 90
Yes,
is
sir.
a cutoff limit, isn't
Yes,
it?
sir.
And
Yes, sir.
to ensure that you would like to keep the alarm limits of the pulse oximeter appropriately.
Yes, sir.
Okay, no? What is wrong with between 95 and 100? If the 100 is okay for a baby without oxygen supplementation?
Hyperoxia will cause pre-radical injury and
How do you say the so the baby who is not on oxygen and saturation is 100, how do you make sure that, how do you know that that baby doesn't have hyperoxia? That baby is also, that's the question I asked you. That baby also has problem?
no, so that be
You got the question?
no, sir. Once more, sir. Hello, sir. Hello.
Are you able to hear me, or my
Sir.
connection froze?
No, sir. I can hear you. Can I get the question once more, sir?
Yes. See, like your your SpO2 is 100 when a baby is not on oxygen. You
Yes,
say
sir.
that is okay, but when a baby is on, isn't it? What is the difference between these two babies? What
It's
parameter is different in these two babies?
so your voice is breaking, sir.
Oh, I'm sorry, Usha. I think you continue, because here there is a severe. Even though I'm using hotel Wi-Fi, that's a very big problem here. Usha, please continue.
Then
Are
now
you able
we
to
are
hear
able
me?
to hear you, sir. Now we are able to hear
Now
you.
I'm hearing, sir.
So now it is clear, sir. Oh.
Okay. So then the Vishnu Priya, do you want me to go back to question, or you want to skip the question? Up to you.
No, sir. It's okay, sir. I didn't hear the second half of the question, sir.
See, we have made a categorical statement. We both agree upon it that a baby who is on supplemental oxygen, you should not cross the SpO2 more than 95. Baby is not on supplemental oxygen, 100 is quite okay for you. Why? You're saying 100 means oxygen toxicity. So the baby who is not on supplemental oxygen will not have oxygen toxicity. Have you understood the question?
Yes, sir. Yes, sir.
Yes. Try to answer. Otherwise, say pass. We'll not waste time.
We'll pass, sir.
Anyone from the group? Oh, all right. So it is the oxygen toxicity, as you said, is not dependent on SpO2. It's dependent on the partial pressure of oxygen in the arterial blood. PaO.
Hello, sir. Sir, I can't hear you.
Yeah, I think sir's connection, there is some problem with sir's connection.
Yeah, we can't hear part of it. So you started the answer, but we cannot hear.
Okay, so it is like a PaO2 target. Okay, so 90 to 95, that is when you are giving supplemental oxygen.
Yes, ma'am.
This is all based upon some evidence and studies. Okay, so
Okay.
PaO2, what is a normal target in gas? PaO2 for a baby, for a preterm baby. Gas, you get PaO2, PCO2,
yes,
all
ma'am.
the things, no? So
Yes, ma'am.
PaO2, what will be the target?
Around 40 to 50, ma'am.
So that is lower. That is a little bit lesser. Whatever you are saying is, it should be 50, above 50, 50 to 80. Okay, that
Okay,
is
ma'am.
preferable. Okay, you need not have hyperoxia more than 80. So for
Okay,
all this PO2 target and long-term outcome, short-term outcome, our saturation target, whenever we are giving supplemental oxygen, should be 90 to 95.
Okay, ma'am.
Okay, when the baby is in room air and maintaining 100, it is okay. We cannot do anything, and it is okay. PPO2, if you check, it would be around 80 or 70. Okay.
Yes, ma'am.
So now what I was asking, PEEP, okay, FiO2, you told you will see the saturation and you will titrate
Yes,
the
ma'am.
FiO2. So PIP and PEEP, if you can answer this fast, we can move ahead. PIP and PEEP. I am not asking about modes of the ventilator. I am not going into those things. I'm just asking, how will you set your PIP and PEEP? What you will see and how will you decide?
What you will see in the baby, ma, what is
Based on
what
the
is
respiratory efforts, ma'am.
Okay, respiratory
The
efforts, let it be.
retractions.
retractions.
Okay.
Retractions.
So seeing retractions, baby is having more retractions. So what do you want to do? So much
We
of
will adjust.
We will increase the PEEP, ma'am.
increase the you tell no, you spell it out. I am not able to.
PEEP, ma'am.
You want to increase the PEEP. Okay, PIP, what do you want to do? More retractions are there. You will see retractions and you will decide on your PEEP. How will
Yes,
you
ma'am.
decide on your PIP? Peak inspiratory pressure. How do you decide on that? What will you see? When you are giving PIP to baby, what will you see?
Lung.
The spontaneous efforts by the baby.
So the answer is chest rise. You will see chest rise, right? That's
Yes,
what you're
ma'am.
seeing. Even in
Lung
ambu,
expansion.
what you are giving. PIP you are giving even in ambu bag. So you
Yes,
will
ma'am.
see whether chest rise is too much, whether chest rise is not at all there, chest rise is optimal. That's what you will see when you are adjusting PIP. For PEEP, positive end expiratory pressure, you will see how much distress, how much retractions baby is having, and you will decide whether you will keep 5 or 6. This is based upon clinically.
Okay, ma'am.
Okay. What other thing you can, what other investigation you will do, or it will help in adjusting the PEEP?
We can do VBG, ma'am.
Okay. What else? BBJ will it help in adjusting the PEEP?
Chest X-ray, ma'am.
Okay. So in chest X-ray, how does it help in adjusting PEEP?
We should look for lung expansion.
What is a normal lung expansion?
No, how many?
Sorry, other pages can just join in and answer.
How many spaces will
How
you
many
check?
spaces, ma?
7 spaces should be there.
Okay, it is 6 to 8 spaces.
Yes.
Okay. So what do you know what mode generally you keep when the baby is put on invasive ventilation? We won't go into the details, but just tell what mode you will keep when you are connecting to a ventilator.
Pressure support mode we'll put on the baby, ma'am.
Pressure support means PSV.
Yes, ma'am.
No, no. When the patient is having spontaneous breaths,
SIMV mode, ma'am.
SIMB mode. Okay, so in SIMB mode, you are setting PAP, PWP, FiO2, then what else you will set?
Set rate.
Rate you will set. So rate how much you want to set in this baby?
Around 40, ma'am.
40, ma'am.
40 to 50.
Okay, so what other thing you will set? You wanted to set 50 rate, okay. FiO2 you want to adjust based on saturation. PAP,
Yes, ma'am.
PWP you will decide and set. What else you will set in
Uh,
SIMB
de-
mode?
PC above peak, ma'am. Delta P.
That is PAP, right?
Yes, ma'am.
So that already you told. PC about PWP is the delta P. If you add both these things, it will be PAP. So already
Yes,
you
ma'am.
told PAP and already you told PWP. What else?
I don't know. The
Inspiratory time do you
TI,
set?
Inspiratory time.
inspiratory time, ma'am. TI.
So how much do you want to set inspiratory time?
0.45.
0.45. Okay, so whenever in a acute condition, RDS baby, if you're suspecting, you will keep a lower inspiratory time and higher rate.
Okay.
Okay, so lower inspiratory time means it is 0.35 or 0.3 you will set.
Okay, ma'am.
Okay, some other modes, you know, SIMB is a pressure mode you told. Okay,
Yes,
any
ma'am.
other mode you are aware of? Just name of the mode you can tell.
Volume control.
Pressure control.
This
PC.
is pressure control, right? SIMB is pressure control.
VCVT. Volume control, ma'am.
Any other volume mode? So you will go and see.
VT.
Okay, the same ventilator, VT. Yes.
VT,
I
ma'am.
think
So you need to set tidal volume and you need to adjust. You will go and see what are the other volume modes in the ventilator. Is there any mode like volume guarantee? Okay, you will see that.
Okay, ma'am.
Okay, now coming to this medication.
are you able to hear me, Usha?
Yes, sir.
Actually, I'm so sorry. My Wi-Fi is going on and off. I was hearing this part actually. I'll just make some, because I think they're totally confused about this ventilation concept, the way they were answering. So I think for those who were answering the question, basically in units, we always use pressure control ventilation. We do not use volume control ventilation. Volume control ventilation is not feasible in units because of the small tidal volumes involved. In pressure control ventilation, we have only use modes. We don't use IME, so you have SIMV, you have SIPPV, and you have PSV. SIPPV is differently called in different ventilators as assist control or PTV and all that. That different terminologies for different ventilators. So basically, you have only these three modes. So the question that Dr. Usha was asking was, can you target tidal volumes, because we can't control the volume. We don't have VCV. So what we do is we use hybrid modes. You target. So different terminologies for different ventilators: volume guarantee, volume targeted tidal volume, various modes. So basically, you are trying to use a hybrid mode. Is this concept clear?
Yes, sir.
Yeah, so you should not consider, and then the now the modern neonatology is all about less is more, which means that you do minimum, make the baby do maximum. So minimum control. So that's why we don't use IMV. The same is true for so probably every ventilation you have something that initiates, something that limits the pressure, and then something that cycles. So only in PSV mode, the cycling is done by the baby, by the flow. Others, you are using time. So that is why PSV probably is the most baby friendly mode. And in a baby who is having, like a small preterm babies, they are sometimes assist control or SIPPV has advantage over SIMB. These concepts are frequently asked in exam if you get stuck up with ventilation, neonatal ventilation. So basics of neonatal ventilation you should always know if you are going to present this case. Is that okay, Dr. Vishnu Priya?
Okay, sir.
Yeah, okay. Please carry on. Carry on. I mean, net is very poor. It's going on and off.
So, like apart from these 5 parameters, whatever you told, PAP, PWP, FiO2 rate, and TA, another parameter is tidal volume. Okay.
Yes, ma'am.
As of now, we have moved towards tidal volume targeted. So, it is not the volume control which we use in PICU or older children. Okay. It is volume guarantee ventilation where you set tidal volume also along with either SIMB or SIPPV.
Okay, ma'am.
Okay, you set your tidal volume also. So excess volume will cause what trauma?
Volume
Polytrauma. Okay, so excess
Mhm.
pressure will cause barotrauma. Polytrauma is very, very important and need to be prevented in a newborn baby. So always you will set a tidal volume and you should make sure that excessive tidal volume doesn't enter the baby's lungs.
Yes, ma'am.
Okay. So what do you think? What no, tidal volume should be set? Suppose this baby, what is the weight of this baby? 1.2 kg, right?
1.04, ma'am.
1.04. Okay, 1 kg baby. So what do you think? What would be the ideal tidal volume that should go inside the baby?
How much ml per kg, ma'am?
Normal tidal volume. So what you should give for anyone?
5 ml per kg, 5 to 7.
Okay, at least 4 ml per kg. If the lungs is bad, you can start at 6 ml. So it is 4 to 6 ml per kg you will set. As the baby improves, you will slowly decrease and bring down to the least tidal volume, that is 4 ml per kg. Okay, fine. So this you will go and see. Once you will put the tidal volume, everything you will set by yourself and you will see how is volume guarantee working with SIMB mode or assist control mode. So you will also put the tidal volume and you will see. Okay. So that is one of the techniques. So the pressures should be titrated, FiO2 should be targeted to avoid injury in invasive ventilation. You should go for volume guarantee ventilation where you or targeted tidal volume. Different ventilators have different names. So this volume guarantee ventilation, when you go, you will limit your tidal volume. Okay, so that injury does not happen. So all these things you need to do in an invasive ventilation if you are going to give. And as you told initially, you have to wean off the baby to non-invasive support as soon as possible. Okay, so let's leave this ventilator mode and let us come to this medication. What medication do you think would have been given to the baby?
Surfactant, ma'am, for lung expansion.
Surfactant for lung. So if this baby is intubated, so how long will you take? What surfactant are you giving? What is the dose of the surfactant? And what is the use of the surfactant? So when will you give surfactant? All intubated babies you will give surfactant?
No, ma'am. If the baby required any intubation at birth.
Okay, intubation in delivery room. Okay, then?
Yes, ma'am. Requiring FiO2 of more than 30% on ventilator.
Very good. So FiO2 requirement is more than 30%. Then what are the things you will see?
And lung expansion also we'll see, ma'am. How is the lung expansion?
How do you see that?
On a chest X-ray we'll see.
Okay, so all these things you will take into account and you will give surfactant. So how much dose did you give for this baby, 1 kg baby?
This baby we give 5 ml per kg.
And how will you give? Quickly.
5
ml
per kg Curosuf was given, ma'am.
Okay, very good. So
Neosuf, ma'am.
Okay, how did you 5 ml per kg Neosuf? How did
via
you?
insure technique, ma'am.
So what is insure technique?
Intubation, surfactant, and extubation, ma'am.
So did you extubate this baby after surfactant immediately?
No, ma'am.
Then why do you say insure technique?
Rapid bolus administration.
Okay.
How to the method you use? I mean, madam is asking the procedure probably, ma'am.
So baby is having ET tube. How do you give?
Yes. We'll insert a feeding tube into the ET tube. We'll measure the size of the ET and the feeding tube, and then insert and give in 4 liquids, ma'am.
Okay, sir. Oh, okay, okay. So this is not in-shoe technique. Okay, this baby is already
Yes, ma'am.
intubated. You are giving in the ET tube. Fine.
Yes, ma'am.
Okay. So colostrum you have started. Sugar monitoring. Why sugar monitoring is important?
Baby was a preterm baby and also an infant of diabetic mother, ma'am. So more prone for hypoglycemia.
Okay. So come to the next slide.
On day of life 2, baby was weaned off from ventilator at 24 hours of life, and minimal O2 support was given via machine through nasal prongs. At 32 hours of life, in view of worsening of distress, sepsis workup and chest X-ray was done, which was told to be abnormal, and the baby was started on antibiotics. Baby also developed jaundice on day 2 and was treated with phototherapy for the same. Express breast milk was started via tube feeds.
So
And
at 32 hours of life, still the baby is on. Now the baby is on nasal prongs, right?
Yes, ma'am.
Okay. So you have extubated at 24 hours and worsening at 32 hours.
Yes, ma'am.
What can be the, leave alone the investigations, what can be the reason for a baby who had RDS extubated on nasal prongs again worsening? What are your DDs?
Any sepsis, ma'am? Any sepsis?
Okay.
Pneumonia.
So it is early onset or late onset?
Early onset sepsis, ma'am.
Okay, fine. Then early onset sepsis, one possibility then.
RDS itself can be a possibility, ma'am.
Okay, so
baby is improved, no? Baby is improved. Any other possibilities? Any other pathology anywhere which could have probably the reason?
Any congenital heart disease?
So which congenital heart disease will present with
PDA,
distress? After 2 hours of
PDA, ma'am.
Okay, so PDA you want to keep as a possibility. Okay, fine. EOS, RDS itself has not improved, but we have prematurely extubated. Okay, PDA, what else? 3 things you have told. What else?
Sorry, 30 minutes more, and can we just proceed with the presentation, please? Hello, Dr. Usha.
Yes, sir. Yes, sir. Yes.
30 minutes are okay. So
Yes,
can you
yes.
just
You can start. You can continue.
Baby developed jaundice on day 2 and was also treated with phototherapy. Express breast milk via tube feeds was started, and baby was tolerating well. Screening echo was done on day of life 2, which showed a small heart defect, and screening USG cranium done was found to be normal. On day of life 3, baby was having frequent episodes of apnea, and for which IV medications were given, and tube feeds were gradually increased, and baby was tolerating well. On day of life 6, in view of abnormal heart sounds, repeat echo was done, which showed increase in the size of the defect, for which some oral and IV medications were given to enhance the defect closure. As the oral and IV medications failed to correct the cardiac condition, parents were told that baby might require surgical intervention for this need.
So what other clinically, what will you see in this baby who has had a heart defect? You are telling medication. What
Yes, ma'am.
medication, what heart condition, what medication, clinically, what will you see? Can you tell it quickly?
It can be a PDA, ma'am. There will be bounding peripheral pulses, hyperdynamic precordium, wide pulse pressure, and systolic thrill can be present in the left upper second intercostal space. A continuous murmur can be heard, and frequent apnea and high O2 requirement can be there, ma'am.
So when do you say it is wide pulse pressure?
More than 25 mm.
25.
Okay, so and what are the medications you have used for this heart condition?
We can give paracetamol, brufen, and indomethacin, ma'am.
Fine. Okay, next slide.
On day of life 7, baby was weaned off from machine and was on minimal O2 support via nasal prongs. KMC was initiated, supplements were started, and antibiotics were stopped. On day of life 10, in view of recurrent episodes of apnea and increasing distress, baby was restarted on O2 support via machine through nasal prongs. And since the baby had persistent respiratory distress, some IV medications were also given for improving the cardiac function. Mother was told that baby had recurrent episodes of apnea, for which some blood transfusion was given twice. And trial pallidi feeds were started on day of life 21, but baby developed distress, and so tube feeds were continued. Eye examination was done after second
What
week.
can be the cause for this recurrent episodes of apnea?
PD itself can be.
Okay, PD you had already told. What else can be the cause?
Anemia, ma'am. Anemia.
Okay.
Hypothermia, hypoglycemia,
then what
hypocalcemia.
Else? Okay, then what else?
Intracranial hemorrhage, intracranial infections.
So when is intracranial hemorrhage common? Day 10 or when it is common?
It is common in the initial 72 hours.
Fine. And then it is unlikely, no, at this point. Okay, yes, hypothermia, hypoglycemia, then what else?
Sepsis, pneumonia, meningitis.
Okay, sepsis, meningitis, and pneumonia. Okay. Yes, then eye examination, carry on.
Eye examination was done after second week and was advised follow-up. Currently, on day of life 33, baby continues to have mild respiratory distress, requiring O2 via nasal prongs to maintain the oxygen saturation. On full feeds via tube with supplements in the form of packet and oil, which was mixed with EBM, tolerating feeds well and showing improvement in weight and not immunized.
So what is the supplement you are mixing in the packet?
HMF and MCT oil.
Why you need to mix all those things?
For weight gain, ma'am. To increase the calorie
so
calorie
did you
dense.
Mention anywhere about the weight gain of the baby?
Ma'am?
Did you mention anywhere about weight gain of the baby till now?
I have mentioned in the anthropometry, ma'am. Just
the present weight, right? That is the
present weight. Yes, ma'am.
What else we need to know? Suppose baby is 1 kg.
Yes, ma'am.
Will the baby start gaining weight from the day 2?
No, ma'am.
Then what else will happen?
There will be weight loss.
So when do you expect weight gain? When will the baby reach birth weight again? This baby.
After 7 to 10 days of postnatal age, ma'am.
Okay. Anyone else?
Preterm.
After 14 days, ma'am.
Okay. Did you say when did the baby reach birth weight or when did the baby started having weight gain? Anything you told? So that also need to come in your history. Okay.
Yes, ma'am.
When the baby reached full feeds, that history was also not there. When the baby reached birth weight, that history also should come. Okay. If the baby is reaching birth weight by 22 days, it is not normal, right?
Yes, ma'am.
At least by 14 days, around 2 weeks, baby should have reached birth weight. So that history should come so that we have an idea why you added MCT oil, all those things.
Okay, ma'am.
Okay. So fortification, why do you do?
For calorie rich, to increase the calories, ma'am.
For calorie or predominantly for something else? So it is mainly for protein, right? Calorie and mainly for protein.
Okay, ma'am.
Okay. So you will go and see what are the composition. So it provides not only provides calories, mainly it is for protein. Protein is also only 1.1 gram in 100 ml milk, right? Breast milk.
Yes, ma'am.
So you need to see how much protein fortifier will give, what other extra nutrients the fortification is giving, like calcium, phosphorus, vitamin D, all those things you need to see. Okay, carry
on. So family history, mother's age is 27 years and father's age is 36 years, non-consanguineous marriage, no history of any infant death or preterm deliveries in the family, and they belong to upper lower class according to modified Kupaswamy scale. Summary, 33 days old early preterm female baby delivered by emergency LSCS in view of reduced fetal movements was admitted in NICU with respiratory distress syndrome, which was treated with the surfactant replacement therapy with early onset neonatal sepsis, neonatal jaundice, apnea of prematurity, anemia of prematurity, acyanotic congenital heart disease, probably PDA, on antifailure measures, tolerating feeds, gaining weight, not immunized, and awaiting surgical intervention.
Carry on.
General examination. The cry tone activity of the baby was good. Posture, baby was lying supine in the radiant warmer with upper limbs flexed and lower limbs extended. And baby was awake and looking around, and color was pink. Vitals, temperature was 36.5 degrees Celsius. Heart rate was 142 beats per minute.
What
Bounding
is the
peripheral.
disadvantage of giving nasal prongs, Dr. Vishnu Priya?
Nasal injury will be there, ma'am. And it can be a discomfort for the baby since most of the babies are nasal breathers.
Okay, carry on. Next.
No radial or radiofemoral delay. Respiratory rate was 58 per minute, abdominothoracic type with periodic breathing. Blood pressure was 58 by 32 mm of Hg in right upper limb. MAP was around 48. Pulse pressure was 26 mm of Hg. CFT was less than 3 seconds. And saturation was equal 98% in right upper limb, 99% right lower limb, 97% in left upper limb, and 96% in left lower limb. And babies on CPAP.
Life is 33, right, Vishnu Priya?
Yes, ma'am. Yes, ma'am.
So why do you say on CPAP? Baby is on nasal prongs, you told, right?
Yes, ma'am.
Then now why do you say SpO2 on CPAP?
Ma'am, at present baby is on CPAP via nasal prongs, ma'am.
I don't understand. CPAP via nasal prongs.
O2 prongs, ma'am.
So from the O2 flow meter, directly prongs is connected to the baby, right?
Yes.
No.
That is not CPAP. Okay. That is just a nasal prongs. And you need to tell how much liters per minute it is going. Okay, it is not CPAP. CPAP means there should be a humidifier, it should be a blender, there should be something delivering bubbling, something delivering PWP. This is not CPAP, okay? Whatever photo
oxygen by prongs only, ma.
Oxygen by prongs. Okay, go to next slide.
So anthropometry, at birth, weight was 1.04 kg, around 10th to 50th centile. Current weight is 1.38 kg, 3rd to 10th centile. Head circumference 25.5 centimeter at birth, 50th centile. And current head circumference is 27 centimeter, 3rd to 10th
It's
centile.
9 o'clock.
And length is 39 centimeter at birth, 50th to 90th centile. And current length is 42 centimeter, 10th to 50th centile.
So which chart is this, Dr. Vishnu?
Fenton's chart, ma'am.
Fenton's chart. Go to the previous slide. So do you want to comment on this head circumference? This is a 28 weeker, right?
Yes, ma'am.
Okay. And head circumference is 25.5 centimeter at birth. Now it is 27 centimeter. What do you think?
There is a reduced increase in the head circumference.
That's what do you expect? Why are you saying reduced? Leave alone the chart. Just to say how much it should be. After 33 days, how much it should be. Suppose, but birth it was 25.5 centimeter.
Yes, ma'am.
How much do you expect at the end of 4
centimeters it will increase, ma? How many centimeters it will increase?
2 centimeters.
0.9 centimeter per week, ma'am.
Okay, it is 2 to 2.5 centimeter, right? First month it should increase
2 centimeter per month.
At least by 2 centimeter. Okay, should be around 27.5 or 28 centimeter. First 3 months the rate growth is rapid, right?
Yes, ma'am.
Okay. Okay, so more than the current weight, what you need to, current weight has to be brought out in anthropometry, no doubt. But also you need to concentrate. In the history, as I told, the most important history is when did the baby reach full feeds? Okay. Transition to Palada, you had mentioned. I agree. Okay. When was fortification started? Okay. When the baby reached birth weight.
Okay.
Okay. And weight gain for the past 3 days and past 1 week. Okay, that would give an idea about whether baby is growing well or not. So newborn case, mostly it is the course. Okay, examination is Examination is important. Many things you will pick up, but most important thing where you will arrive at the problems in the baby is course. NICU course. NICU course, everything you need to tell in the fine details. Suppose ventilation, respiratory support, how many days you didn't tell clearly about duration of invasive ventilation, non-invasive ventilation. Okay. So you told we extubated at the 32 hours, baby was on nasal prongs, again went into, again required invasive respiratory support, again extubated to nasal prongs. But you need to tell what is the duration of invasive ventilation and how many days baby was on CPAP. Now how many days baby is on oxygen prongs. How are you titrating your FiO2?
Okay.
All these things are important when you tell about ventilation or respiratory support. These are very, very important. NICU course is the most important thing when you are presenting a newborn case. Okay, it's not like older children where you will have many findings to elicit. It is mostly by meticulous history and meticulous NICU course.
We have one doubt, ma'am. Actually, Dr. Usha, ma'am.
Yes,
we thought of, I mean, from the parents' point of view, I mean, how they will tell about the CPAP when it is being done.
yes,
How
sir.
to
The
put
same thing.
because we had a doubt in our department also how whether to put it like that.
Okay.
But some of them are told this from the parents' point of view, we can't tell, okay, at what days it is, I mean, this kicks in because it's not a profile of the patient.
Yes, sir.
If
we are asking from the parents, we can just say, anyway, mother or father will be alone. We can just ask whether tube was in the mouth or in the nose.
That's only, ma'am, actually. So the presentation was made little simpler because we wanted to be put it on the like from parents' point of view, okay? Because I mean, as a present, it's not the profile of the baby completely. Okay. We have to present as per the parents' point of view, because the history was from the parents' point of view.
Yes, sir, agreed. So if that is the case, then you can say duration of invasive. How many days baby was intubated? How many days baby was on prongs? At least that much you can tell.
Yes, ma'am.
You cannot tell when the baby reached birth weight, but you can tell what is the weight gain for the past 3 days. Any mother will be aware of all those things. My baby is not at all gaining weight. My baby is gaining weight for the past 3 days. Any mother will be able to.
Yes, ma'am.
That thing has to come out because that is an important history to know whether baby is growing well or not. Okay. And eye examination, as you told, eye examination, art scan, ultrasound aid, whether anything abnormal is there or not, all this history you will be able to elicit from the mother. And even if you are mixing in the milk, mother will be aware. For the past 2 weeks, we are mixing some powder in the milk and giving for increase for weight gain. That thing mother, most of the things mothers will be able to tell because we allow mothers to stay with the baby. Okay.
Yes, ma'am.
And KMC also you need to tell duration of KMC. That also mother will be able to tell, right? And another thing is non-nutritive sucking. That also has to be brought out. So all these things are very, very important from the developmental point of view in a preterm baby. Okay?
Okay, ma'am.
Fine. Even when the baby is in prongs, you can give non-nutritive sucking, right? So that thing also should come. And whether mother is involved in giving paladay feeds, all those things.
Okay, ma'am.
Okay, so here you could have brought weight gain for the past 3 days.
Okay, ma'am.
Yeah, next slide.
Okay, ma'am.
Next slide.
So head to foot examination was normal. Hypopigmented patch was present over the gluteal area, spreading to the sacral area, ma'am.
Was it present in the birth or was it?
No, ma'am. Past 1 week only it is present.
So what it could
not from birth.
What
it could have been due to some diaper dermatitis or contact dermatitis.
Fine. Next.
Ballard scoring, since a baby was on a ventilator and sick, we couldn't able to see the neuromuscular scoring. Only physical maturity.
Is it relevant to put Ballard scoring now or 33 days of life?
No, ma'am. At birth only, ma'am. At birth, we were able to see only the physical maturity. Scale for the baby. Neuromuscular score we could not be able to do, ma'am, since the baby was sick.
Okay. So unless some lines are there, other things we should be able to do, right?
Yes,
only if some line is there in that particular hand or leg, we won't be able to do. And yield to ear might be difficult. Other things, posture of the baby, you can easily see. Square window, you will be able to easily see. arm recoil also you will be able to easily see. Upper limb and lower limb angles also you would be able to easily see. Okay, fine.
Okay.
Can you put the ballot scoring now?
No, ma'am. No, we
Session
cannot
end.
put, ma'am.
So how
No,
long?
ma'am.
So how long can you give? How long can you do this ballot scoring after birth?
Within 72 hours, it should be done, ma'am.
So within preferably within first 4 days or at least till 1 week. After 1 week of life, it is not relevant to do ballot scoring.
Okay, ma'am.
Next slide.
Systemic examination. I'd like to start with CVS examination. Inspection. Chest wall is bilaterally symmetrical and movements are equal on both sides. No engorged veins. Hyperdynamic precordium is present. Visible pulsations are present in the left, third, fourth, and fifth intercostal spaces. And mild subcostal and intercostal retractions are present. Palpation. Apical impulse is felt in the left fifth intercostal space, 1 centimeter lateral to the midclavicular line. Hyperdynamic apical impulse is same. Systolic thrill was present in the pulmonary and the mitral area, and no parasternal heave. Auscultation. S1, S2 heard in all areas. Grade 5 continuous loud missionary murmur is heard in all areas, radiating to axilla and back. RS, bilateral chest wall symmetrical, chest movements were equal on both sides. Mild subcostal and intercostal retractions are present. Abdominothoracic type of respiration. Bilateral normal vesicular breath sounds are heard, no added sounds. Per abdomen soft, no distension, no visible peristalsis. Abdomen moves equally with respiration. Liver was palpable 2 cm below the right costal margin and was soft in consistency. Liver span was around 5 cm. Bowel sounds were heard and umbilicus was healthy and hernial orifices are free. CNS, baby was awake and looking around, lying supine in the radiant former with upper limbs flexed and lower limbs extended. Spontaneous symmetrical movements of all 4 limbs are present. Cranial nerve examination was normal. Neonatal reflexes.
General activity, how was the activity? Did you tell about that?
Ma'am. Yes, ma'am. Cry tone activity was good, ma'am.
Okay, tone we cannot comment, right? Tone will be less only. This is a
Yes,
preterm
ma'am.
baby, right?
Yes,
So
ma'am.
cry, then what else you will see in the baby?
Activity, movements of the limbs.
Okay, movements of the limbs, whether it is symmetrical. Okay,
Yes, ma'am.
it should not be stereotypical. Then what
Yes,
else?
ma'am.
Consolability of the baby you will be seeing. Okay,
Yes, ma'am.
and you say, as you told, yes, CVS examination and abdominal examination might be more relevant. And this thrill and all can be avoided. Okay, in newborn
Okay,
baby.
ma'am.
Just
Okay,
presence
ma'am.
of murmur, apical impulse where it is felt, that is enough. That much only you
Okay,
can
ma'am.
make up. Other things you cannot make out. Okay,
Okay, ma'am.
fine. Next.
Cranial nerves were normal. Neonatal reflexes, rooting
Go
and
to
sucking
previous
reflex.
slide. Go to previous slide.
Yes, ma'am.
Okay,
One,
so these 5 and all, 5, 9, 10 and all palatal movements, instead of telling that 5, 9, 10, what you
Yes,
need to
ma'am.
observe? 5, 9, 10, what you need to observe?
Rooting reflex we can see, and palatal movements also we can see while crying, ma'am, and sucking reflex.
Okay, you need to see sucking of the baby.
Yes, ma'am.
Okay, and if you are giving palliative feeds, you need to see swallowing of the baby, whether there is any regurgitation.
Yes, ma'am.
Okay, all those things will indirectly give about 9, 10.
Okay, ma'am.
Okay, because you cannot go and check gag reflex, all those things. It might
Yes,
again
ma'am.
elicit apnea in the baby.
Yes,
Okay,
ma'am.
you need to do all these things. You need to check feeding of the baby.
Okay,
Okay,
ma'am.
suppose if it is a term baby and if the baby is feeding, how long do you observe feeding of the baby to comment whether everything is going normally or not? Your IMNCA is telling, no, you need to observe the
Yes,
baby for
ma'am.
a specific time when the baby is feeding. So how long do you observe? At least
20 minutes, ma'am.
so it is at least for 4 minutes. You go and see IMNCA. Okay, so
Okay,
it is
ma'am.
for 4 minutes, and what are the features you will observe during feeding? Okay, next.
Neonatal reflexes, rooting and sucking reflex present. Palmar and plantar grasp was present. Morose reflex was symmetrical but incomplete, ma'am. The flexion and adduction part was not present, ma'am.
So when do you expect all these things to be present? Complete morose.
34 weeks, ma'am.
Okay, so what are the components that will appear first initially? Morose. When the baby is premature, what are the components of morose?
Abduction of the shoulder, extension of the elbow, opening of hands, followed by flexion of the elbow and adduction of the shoulder,
So which
followed by
component
crying.
which component will appear first?
Uh,
So incomplete means it should be in the same order, right? The whichever
Yes, ma'am.
developed later will not be there.
Yes, ma'am. Abduction will be first, ma'am.
Okay, opening of the hands will come first. Okay, followed by abduction.
Okay.
Okay, next.
Motor system tone was appropriate for age in all 4 limbs.
Okay, tone for tone, no? You can again tell this Ballard score for Ballard scoring alone. You need not tell popliteal angle, all those things. Ballard scoring is now irrelevant. 33 days of life.
Yes,
So you
ma'am.
can mention all those neuromuscular parameters in the tone. Okay.
Okay, ma'am.
Okay. You need for you it might be a little bit higher, but in the tone assessment, always in the newborn, what we used to see is popliteal angle, square
Yes,
window. Okay, adductor
Yes, ma'am.
angle. For upper limb, you will see if tone is good or not. If arm recoil is good. If you're extending the arm and leaving it, if it is instantly recoiling, then tone is good. Square
Yes, ma'am.
window angle, you will see. Lower limb
Okay.
popliteal angle, you will see. Okay,
Okay,
adductor
ma'am.
angle, you will see. All those things you will see in a newborn baby.
Okay, ma'am.
Okay, this we might not know do in a bigger baby. For bigger child, in a newborn baby, it is by using these angles we will know whether tone is normal or decreased or increased. Okay,
Okay, ma'am.
next.
So diagnosis, early preterm female baby, appropriate for gestation age.
Rama ma'am has commented active tone and passive tone. All these angles,
Okay.
whatever you are seeing, no, in the baby. Arm
Okay.
recoil, square window, popliteal angle, adductor angle, all those things are passive tone. You are doing
Okay.
something, you are measuring the angle. Okay, baby
Yes,
is not actively doing anything. You are keeping the legs like that and you are measuring the angle. So those
Yes, ma'am.
things are passive tone. Active
Okay.
tone is when your baby is in supine, when you are pulling the baby to sitting position.
Yes, ma'am.
Okay, whether it is at least momentarily standing for
Yes,
few
ma'am.
seconds. Those are used for assessing flexor tone, extensor tone of the neck, all those things. Wherever baby has to do some work, it is called as active tone.
Yes, ma'am.
Okay, you can go and see how to
Okay,
assess all those things. Videos will be present. So how to assess active tone, neck flexor, neck extensor during active tone assessment. So in newborn, always we tell it as a passive tone and active tone. Passive tone are all angles, popliteal angle, adductor angle, square window, arm recoil, all those things are passive tone. Okay. And
Okay.
primitive reflexes you have already told. Okay. So what other reflexes can you see at birth? Apart from this.
Asymmetric tonic neck reflex, ma'am.
Very good. So were you not able to elicit ATNR?
Actually, baby is on CPAP, ma'am, so we are not able to examine detail.
Baby himself will elicit ATNR. Okay. When you observe a baby for 5 minutes, 10 minutes, when you see when the baby is turning towards one side, it will
Yes, ma'am.
automatically, he will automatically elicit the ATNR for you. Sometimes when you examine, it might not be there. But when you are doing other examination, you can observe that whenever it is turned towards one side, the limbs on that side will be extended and opposite side it will be flexed. So ATNR will be normally elicited. Other thing what you can check is stepping reflex, placing reflex and stepping reflex. Okay, other reflexes which you need to check. Okay. Okay. Next slide.
Diagnosis, early preterm female baby, appropriate for gestational age, infant of diabetic mother, born at 28 weeks plus 5 days of gestation, with postmenstrual age of 33 weeks plus 3 days, and postnatal age of 33 days, with a birth weight of 1.04 kg, with perinatal depression, respiratory distress syndrome, post-surfactant replacement therapy, early onset neonatal sepsis, probably a congenital pneumonia, apnea of prematurity, anemia of prematurity, neonatal hyperbilirubinemia, bronchopulmonary dysplasia, acyanotic congenital heart disease, significant PDA with congestive cardiac failure on anti-failure measures.
So why do you say BPD, Dr. Vishnupriya?
The baby is 33 days old and still on O2 rec, still on CPAP.
Okay, so baby has to reach how many weeks to tell whether it is clear-cut BPD? When you will assess for BPD?
36 weeks, ma'am.
36 weeks. As baby has reached 36 weeks PMA?
No, ma'am.
No. So it is little difficult to label it as BPD. Though probably it is evolving BPD, we cannot label still.
Okay.
Okay. So now EONS, what did you say? Points in favor of EONS? Any blood reports, anything did you tell? Or X-ray finding, anything did you tell? Like mother
ma'am.
told that pneumonia, baby is having pneumonia, baby is
Yes,
having
ma'am.
some...
Sepsis workup and chest X-ray was done, which was
did the mother
told to be abnormal.
Did the mother say you that baby had infection, baby had pneumonia?
ma'am.
Yes.
Yes, ma'am.
Okay. So if that is the thing, then why you are labeling? So apnea of prematurity, when you will label?
If there is cessation of breathing for more than 20 seconds.
Okay, that is the definition of apnea. When it is called as apnea of prematurity.
If it develops after 1 day and within 7 days, 1 to 7 days, ma'am.
The baby is having pneumonia and developing apnea. Is it called as apnea of prematurity?
No.
So
No, ma'am.
apnea of prematurity, transient tachypnea of newborn, all those things are diagnosis of exclusion.
Yes,
When
ma'am.
you're not able to find out any other cause for apnea, you will label it as apnea of prematurity. You will attribute it to prematurity when already so many causes are there. Baby is having one-time anemia, baby is having one-time sepsis. So automatically that will be cause of apnea. So I am telling this jaundice caused apnea. Baby had jaundice which resulted in apnea. What do you want to say? Can jaundice cause apnea?
Yes.
No.
Yes, ma'am.
Yes, ma'am.
How will it cause apnea?
Encephalopathy, ma'am.
Okay. So which chart will you use for jaundice?
AAP nomogram, ma'am.
This baby will you use?
Preterm
Nice guidelines.
Nice guidelines.
Okay, so now this baby had apnea on second week, no? Second week or what? When did you say this baby had apnea?
On third day, ma'am.
Third day.
From third day, baby was having apnea, ma'am.
Okay. So third day, you also found out that baby had some infection in the lungs.
Yes, ma'am.
Okay. So can it be ventilator associated pneumonia? Ma'am has asked. Can it be VAP?
Yes,
Maybe you have intubated also, no? Can it be VAP?
But baby was extubated on day 2, ma'am.
Okay.
Yes, ma'am. It can be, ma'am.
Can be VAP also, right?
Yes, ma'am.
So if the baby develops after 48 hours of intubation or within 24 hours of extubation, anything is satisfying, it can be there. So then one another question is there. When does anemia of prematurity appear? So when did this baby require transfusion?
On day of life 20, ma'am.
Okay. So can this baby have anemia of prematurity on day of life 20? When will this baby 28 weeker will have an anemia of prematurity? Around what weeks?
After 2
Preterm
weeks,
babies,
ma'am.
ma'am.
After 2 weeks, ma'am.
It's usually around 4 to 6 weeks,
Okay.
right? Okay, baby can have at 3 weeks also. What are the things could have increased the chance of anemia in this baby, whichever you are talking about?
What are the chances for anemia, ma'am? Why the child is developing anemia? Any other possibilities? Priya?
Sir, preterm itself.
Okay, prematurity already you told us.
Yes,
okay. Then?
Baby is there in the NICU, so any other possibility?
Iatrogenic can be caused.
Iatrogenic frequent sampling.
Repeated sampling, all those things can lead to anemia of prematurity and can exaggerate the anemia. So it might present little bit earlier also. Okay.
Yes, ma'am.
Sir, any other questions, sir? Manoj, sir, do you want to ask? So another thing is total parenteral nutrition. Like I want to just know whether baby was given any amino acids or fat, but then you are telling that mother is not aware of that information, right?
Yes,
So
ma'am.
it's okay. If you are able to get that information, you can tell that also. And another thing is when was the central lines, all those, you can ask that. When was the line in the umbilicus was removed? All those
Can
things.
I ask a question? If you don't mind, can I interfere?
Yes, carry on,
Yes,
sir.
sir.
It's over, sir. Carry on, sir.
Can I ask a question?
Yes,
Because
sir.
is it necessary that you have to mention all the neonatal, immediate neonatal events unless there is a specific sequelae of that particular event? Because here the diagnosis seems to be having so many things. So this child is survived and beyond 28 days. So I would like to know from neonatologist, because I am not specialized in this. So I would like to know from you, is it necessary that we have to tell all the essential
Yes,
things which have been going on right from birth till this
I
day?
think we have
And
to say,
the
sir,
present condition should be mentioned, no?
I think we have to mention all this, sir. I think.
Okay, that's what I wanted to know.
Yes, sir. I think she has to say it. I think everything has a bearing on the present condition, sir. I think she has to say.
Because child has survived so many things and then child has come. So I was wondering whether, of course, follow-up is important.
So whichever information mother is able to say, she can tell, sir. Otherwise, she can just say that was not able to elicit the test.
Yes, ma'am.
Then Manoj,
Thank
sir.
you. Thank you very much, Dr. Usha. So it was a very nice discussion we have had. But as PRC sir has pointed, it became more a case discussion rather than a KPG presentation of a individual case. I mean, given the case just chosen, probably it is a bit difficult to concentrate a bit more on the examination part as well. But even otherwise, I think the discussion was very exhilarating. So thank you very much. May I now request the judges to make their comments. May I call upon, may I request Professor Srinivasan sir to start with his comments, please.
Srinivasan just now passed this thing, just my clarified whether all the essential.
You said you wanted to ask a question. You didn't.
Yeah, but of course, I have been sending messages periodically about the quality of questioning and probing. And of course, it's very interesting and of course, it's very educative and academic. And I hope the PGs who are attending are writing down all these questions and so that they'll be able to answer if such a case is given. Yeah, it is at the level of DM examination. Okay, and not MD examination, but it's very essential nowadays. Yeah, given a case, newborn case, there is always a newborn case given. Thank you. And of course, counseling is very important for the mother after discharge and subsequent. That's part of the important thing to be mentioned. Okay, how often the mother has to be coming for various examinations, because there has been litigation about retrolental fibroplasia in a child, so all these things have to be told to the parents so that how often they have to come, etc.
Thank you, sir. Professor Amma, ma'am, your comments, please, ma'am.
Yeah, it was very, very exhaustive. And as somebody mentioned, normally we don't give a very extreme preterm and all for the exam, because I think, first of all, we can't mobilize this kind of a baby to the exam hall. And it will be mainly theoretical kind of questions. But I think Usha did a fantastic job of covering all the, everything about an extreme preterm, starting from the antenatal history and all that. And I think Vishnupriya also did a good job. I think some things, of course, she didn't understand, especially Manoj's physiological some questions. Otherwise, it was an excellent session.
Thank you.
Seeing
Thank
a
you,
question, I felt like doing neonatology now at this age.
Thank you.
Thank you. Thank you very much, sir.
Thank you, ma'am.
Professor,
Thank you,
yes, sir.
Thank you. So it was very interesting. I just made some remarks. Actually, the current days PGs, they have to be very well versed with the neonatology. It's not that only the DMPGs have to know, because they also have to face all these situations. So we never know when they are posted at the district level or in the medical college, they have to be on par. So they cannot be lagging behind. Actually, what we do as a MD newborn examination is a sham. We are not doing any examination of the newborn. Most of them are very stable, just about to be discharged newborns. and hardly any examination is being done. And it's just one of the short cases. Okay. I think it is not commensurate with the importance that is to be given to the newborn at the current situation. But this is actual. So it's always a good opportunity for postgraduates and all of us to learn and update regarding the current trends and the concepts. I mean, see, there are many aspects, the concepts which Dr. Usha and Dr. Manoj discussed and Dr. Arul also discussed extremely well. Okay, that is what, even one or two questions, when the postgraduates are asked about the concepts, they will have to, if they are answering well, you know that they are going to be the teachers for the undergraduates and others. That's what we are actually testing the postgraduates, not just the answers and the reason behind the answers, so that they can be the good guides and other things for the mentors for the undergraduates as well as the younger postgraduates. Actually, we are looking at that in the postgraduates. So that was tested very well. So I actually felt this, each of our neonatology presentation, some aspect or other is being given a lot of importance. In some, the neurological examination. Here, it's mainly the NRP and regarding the basics of ventilation. I think all of these actually go to make a comprehensive added knowledge. So I welcome it. Okay, I don't have any problem with that. Though this is not the actual situation in the MD exam, that doesn't matter. When they know more, it's not a problem.
Thank you, sir. Thank you very much, sir. Professor Ramesh, sir. Your comments, please.
Again, a complete and a comprehensive, perfect presentation with more emphasis on management and especially the ventilation part of it. As Arul Kumran rightly pointed out, in the MD examination is totally different because they are given a case at that point of time. They take history, from the mother, physical examination, systemic examination, and they are going to give a diagnosis, and based on the diagnosis, how they are going to manage that case. But this is a teaching session, so the moderators and the students should be aware that it is a teaching session and it's not just an examination case. And I should appreciate the presenter. She single-handedly took the assault of all the questions. I always say that all the presenters should be involved. So you can even make it, please note Dr. Tirumurugan. They may be informed 30 minutes for history, 30 minutes for clinical examination, 30 minutes for diagnosis and investigation, then 30 minutes for discussion and management of complications. Arul Kumran also did a good job by giving it like a internal examiner. He was also giving clues to the students. I didn't see the face of the students. That is again disappointing because we need to see their face and body language, how they take the questions, whether they are trying to just guess or they are talking from their heart. All these things we need to know. And the students should come prepared for a detailed presentation because now they have access to the case sheet and other things. So what I do in my department is I just tell in the previous day when I allot the case itself, it's going to be an examination case. They have no previous data. They have the mother and the baby only. Or I say that you just go through elaborately about the case sheet, investigation, and they have to discuss with the ward rounds about each and everything about it. Anyway, it's a wonderful teaching experience. I think the moderators and the students would be adequately informed what to expect so that they are prepared. And special congratulations to Vishnu Priya who did a good job. And on the whole, it's an excellent presentation. Thank you.
Thank you very much, sir. We will try to.
One more comment, Tirumurugan.
Solon, sir.
Just before we close, as it is essential nowadays, most of the postgrads immediately go to super specialty, subspecialty, and they are exposed to neonatology posting for so many months. I think to get extra marks for differentiating excellent students to take up neonatology, this is very important. And of course, academically, it's very important to discuss these things, so that postgraduates get interested in various aspects of ventilation, etc. So I think it has served a purpose and very well done. I enjoyed it thoroughly and I could understand and learn something new. Thank you so much.
May I call upon Janani ma'am to give her comments, please. Janani ma'am.
Murugan, can I make a comment?
Oh, yes, sir. Please, sir. Go ahead, sir.
Yeah. Actually, I forgot to mention the postgraduates did extremely well. Okay. I think the other, not only the presenter, other postgraduates are also answering. I understand Ramesh, this thing concerned that postgraduate was not seen because their level of answering was like an asking process. Okay, so
Thank you,
probably
sir.
he wanted to see whether they are really the postgraduates. Okay, congratulations.
Thank you, sir. Thank you very much.
Okay, so thank you very much, sir. Janani ma'am, can your comments, please, ma'am? Anomalous, sir.
Usually she reserves her
Yeah.
comments because she is a real judge. The
Yes.
judgment will be given only
Anomalous,
later,
sir.
only in the marks.
Yes,
Your
sir.
comments, please, sir.
The session was very, very useful for the postgraduates, and I must congratulate the postgraduates for Dr. Vishnupriya for presenting the case very well, a difficult, extreme preterm, and almost answering almost all the questions from all the faculty, Professor Manoj, Dr. Usha Devi, Professor Arun Kumar, and all of them. They were asking, and she was able to answer, and all the other postgraduates also answered well. And this level of discussion also, as the others have pointed out, at the level of slightly above the MD level and maybe DM level, because management of a sick child was discussed extensively. Of course, a lot of things on the concept which Professor PRC sir was stressing. Lot of us who have done our newborn earlier, all the changes, the youngsters are now learning the things newly. They are very good and they are answering well. For old timers, all the new concepts also a revision and the changes we have come to know. Thank you for the discussion. Thank you. Thanks to the faculty and organizers for the opportunity.
Thank you, sir. Thank you, sir.
The last
look
slide,
like-
the diagnosis slide was excellent. She incorporated all the findings. This is how a
Yes, sir.
diagnosis-
Complete.
Complete, correct.
Thank you, sir. Thank you, sir. Looks like we have lost Dr. Manoj's internet connection. So thank you very much. It's been another great day in the postgraduate clinics. This is our 75th postgraduate clinics in the start about 2 years back. And the demand has not gone down. If at all anything, it has gone up. I mean, there was some suggestion about trying to reduce the number of clinics, but given the sheer low interest among the various candidates and the colleges, we are trying
Congratulations.
to
Such a good decision you have made to go on for another year.
Yes, sir,
because there are so many colleges and it gives exposure to so many postgraduates. So I think it's a wonderful deed. And immediately after the conference, immediately I thought there will be a 2 weeks this thing halt, but without any this thing, tiredness, you people have immediately put in. I was surprised that the Saturday class was there. Anyhow, I am benefited. Thank you so much.
And actually, sir, to the last year, the competition was so close that the difference between the first
I
and
saw
second was only
I saw the marks
0.5 marks, sir. It was not very different. So the competition is also very healthy, and we are grateful to all the postgraduates.
It's very important to get exposed to various examiners and this thing from various places. From other parts of India also, you invite faculties and chairpersons. So it gives immense exposure, and then I think this is how we have to prepare our postgraduate, because they are exposed to each and every aspect of pediatrics. Yeah.
Thank you, sir. So let me
also able to see so many good examiners.
Yes, sir. Definitely, sir.
So many good teachers, so many good examiners. So that is also very, very impressive.
Thank you, sir. So let me conclude by thanking the judges for the day, Dr. Janani ma'am, PRC sir, Ramesh sir, Rama ma'am, and my professor Srinivasan sir for being here and then giving their positive encouragement and comments. I would like to thank Professor Arun Kumaran and from Sri Manakala Vinayak Medical College Hospital, Pondicherry, along with her postgraduates, Dr. Vishnupriya, Dr. Reshma, and Dr. Shobna, for a nice case presentation and enthralling the discussion. I think star probably among the three moderators is Dr. Usha. Thank you very much for being patient and kind, and then still sticking up to the points. And Dr. Manoj, it's a bit unfortunate that he's today in a session in I think in Tirupati, so that's why his connection has been a bit spotty. But we loved having Dr. Manoj, and thank you everyone for being here. And then contributing for an active discussion. Hope to see you again next week. Thank you again. Thank you.
Thank you very much, sir. Thank you very much.
Thank you.
Thank you. Good night.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you.
Thank you.
Yeah.
Good night.
Thank you, sir.
Thank you.
Usha ke Jai Pol.
Thank you.
Thank you, sir.
Keep up